First of all, thank you very much for having me. Delighted to be here, and congratulations to Dr. Lewis. It's a great privilege to follow you, and indeed, it's because of pioneers such as Dr. Lewis that we're able to have this discussion today and talk about addiction as a disease and have symposia like this where we can gather together and try to find common solutions to this problem. I have no disclosures really to talk about. I would like to talk about a few associations that I have. Can you hear me okay? I'm having, yeah, in the back? Can you put your hand up? Good? Sort of. Okay. I had the privilege of spending a couple of years as the medical director at Cirque Lodge, and that is an abstinence-based treatment center in Utah, and very proud to have a continued relationship with that organization. I'm a member of ASAM, the American Society of Addiction Medicine, and I'm also a member of International Doctors in Alcoholics Anonymous. I think we're most accurately described as a group of recovering alcoholics who have a professional problem. And then I am a member of Like-Minded Docs, and this is an interesting organization. So many of the members of ASAM are indeed members of IDAA, and ASAM probably is some number of thousands of primarily physicians. IDAA is probably 700 or 800 doctors internationally. And then Like-Minded Docs is a group of 200 or 300 docs who are not exclusively, but primarily doctors who treat the disease of addiction. Many of us have the disease of addiction. And there's a broad scope of practice within that group. Many people who use opiate replacement therapies. All of us believe that there is some importance for the use of medication in the treatment of addiction, but we are all united by the idea that addiction needs to be treated with psychosocial and spiritual interventions as well. And so that's sort of our common ground, and we're all united in the idea that we need to further the science, that we really need to get better at understanding what modalities are specifically useful to any given patient. So I'm going to base my talk today on some excerpts from the 2011 ASAM position paper, and you probably have all seen this in various forms. So the first part of this, addiction is a stress-induced, genetically mediated primary chronic disease of the brain, and you've probably all heard that part. It affects the circuitry that is involved with reward, motivation, memory, and we're going to kind of break that down a little bit. The second part that I think is interesting is, and I think really reflects the involvement of a lot of the like-minded docs in the writing of this paper, and that was that dysfunction in these circuits then leads to characteristic biological, psychosocial, and spiritual manifestations. So this is sort of the idea that the symptoms of this disease are going to be behaviors, right? And that when this circuitry goes awry in the predictable way it does in the disease of addiction, that this is reflected in individual pathologically pursuing reward and or relief. And I want to talk about both sides of that equation. There's a lot of discussion about reward, but there's this other side, what George Koob calls the dark side of addiction, as if there were a light side, where there is relief of suffering, relief of pain by substance use and other behaviors. And this is interesting too, because I think it throws the door open a little bit wider for addiction, that we have to recognize that there are indeed consumptive addictions, but there are other process addictions as well, and that all of these are important. So addiction is a particularly evil and pernicious disease. Particularly true because I think it doesn't look like a disease at all, right? This is a disease that masquerades as lack of willpower. It masquerades perhaps as personality problems, sociopathy, in fact, but it really doesn't look like a disease at all. And it has this kind of key element, right, of self-deception. If we look across the spectrum of disease, one of the most profound things that we see is this lack of insight, this inability to introspect, that we just don't see it quite right, right? Addiction preys on vulnerable people. Addiction preys on people who have been traumatized. Addiction preys on people who have severe co-occurring mental illness. Addiction preys on folks who, whose brains are developing. We're going to talk a little bit about brain development. Addiction is a bully. It has a highly variable prognosis, and this is confusing. It's chronic, it's relapsing. In some people, who saw the Cape Cod movie last night? Just hands up. Yeah, right. Powerful. So some people flame out with this disease very, very quickly. Other people smolder along for years. Others smolder along for years, and then there's an inflection point, and it hits a more accelerated course. And the inflection point is usually some sort of trauma, whether it be, I mean, my sponsor always says it's finance and romance that get this thing going, right? We hit some inflection point and the disease accelerates. And then other people seem to spontaneously remit, right? I mean, we all know them, people who just kind of stop. Did we have that correctly labeled in the first place? Was that really addiction? Was it problem use? What is that? So it's confusing. We don't really have our definitions quite right. And then addiction is culturally and politically divisive, right? It taps into our deepest fears, our prejudices. It threatens our core values: life, liberty, pursuit of happiness, family, love. These things are destroyed by the disease of addiction, and so particularly evil. So what is a disease? Well, quite simply, a disease is is a defect in an organ system that produces a consistent pattern of signs and symptoms. And diseases may be acute and chronic, and one of the difficulties we have with the treatment of addiction is that our medical system in general is designed to treat acute diseases, right? If you have a broken bone, we're extremely good at fixing that. But we're not particularly good at chronic diseases, and I think addiction fits every criteria for a chronic disease. Chronic diseases are treated over time. They're not cured. They tend to have waxing or relapsing and waning or remitting courses. Outcomes very much depend on care over time. And chronic diseases also have both genetic and environmental factors which tend to determine vulnerability. And I'm going to come back to this idea of vulnerability over and over again. Vulnerability to disease. So why is it difficult for us to accept that addiction is in fact a disease? And I think in large part it's because it centers in the brain, right? We have a pretty good understanding of many organ systems, the pancreas, the kidney, the lung. We understand these fairly well, but the brain is still something really of a black box. Right? We lack objective data. There's no biopsy. There's no lab value. If someone comes into the clinic and says, I'm concerned I have diabetes, I have a lab value for that. There's no such test for addiction. And addiction, it manifests as unreasonable behavior. If we were here in the 80s, we'd be having this same sort of discussion about depression. Is depression a disease, right? And there were many at that time who thought, depression was really not. It was a willpower problem. And if depressed people would just kind of, buck up a little bit, they'd be all right. Just try a bit harder. And now we realize that's ludicrous, right? So there are models for these sorts of diseases that center in the brain that don't have an objective, diagnostic criteria in terms of biopsy or lab. They exist. But unlike depression, depression inspires empathy, sympathy. We want to help depressed people, right? Addiction, not so much. Our behavior is so incredibly unreasonable, right? We're going through life like a tornado and shooting our fingers at everybody, and I'm all right. I got this, and it's not a set of behaviors that evoke empathy. talk a little bit about the genetics of addiction. So consistently over time, twin studies, adoption studies have demonstrated heritability estimates of about 50%. That is to say that about 50% of the likelihood that any given individual will develop addiction is directly related to genetics. And when we talk about genetics, we're talking about specific polymorphisms. So we're talking about genes that code for proteins that alter the way we absorb, metabolize, bind drug in the system. And the way these specific gene proteins work alters our predisposition to a disease, in this case addiction. And I want to talk about two examples of gene polymorphisms that are very much in sort of vogue at the moment. There are many, many, many of these, and every day we're discovering more, but these are two that are particularly interesting. One is this opiate receptor, the OPRM1 gene. This is a gene that, if you have this ASP variant, people with this variant have more opiate receptors, and they bind opiate much more avidly than most people do. So when opiate goes in the body of somebody with this variant, they're going to have a very different experience of that drug. They're going to have a different experience viscerally, they're going to have a different experience cognitively, and presumably this was what predisposes them to the development of addiction. Interestingly, because they have more receptors that bind opiate much more avidly, they're far more predisposed to addiction, overdose, and also will have a very much more robust response to opiate receptor antagonists like naltrexone. So a variant that's very interesting. Dopamine DR2 receptors, DRD2 receptors, sounds like R2D2 receptors, but it's DRD2 receptors. So this A1 variant of this has been implicated in addiction in a variety of ways. So people with this variant probably have less of this kind of dopamine receptor than most people do. There is some idea that these people may in fact have what is called a low hedonic set point, low hedonic tone. These are people who perhaps would experience the world through a slightly depressive lens. That's not to say that they would meet criteria for major depression, but they just kind of see the world through a slightly depressive lens. This has led to some people calling the disease of addiction reward deficiency syndrome. This is very, very prominent in addicted folks. Interestingly enough, this variant is also seen in other disorders of impulse control, like ADHD, OCD, and indeed Tourette syndrome. And it was very interesting last night. One of the kids in the movie was talking about her drug use with one of the other lads, and they were saying, yeah, you know, I just have this tendency to get kind of obsessive about everything. I get obsessive about TV shows, I get obsessive about food, right? This is that sort of thing. We just kind of get stuck in these loops, right? Okay. So that's the DRD2 receptor, and we'll come back to that. So addiction is stress-induced, right? Addiction is stress-induced. Now, it's hard to define what stress actually is, but we all know it when we feel it. Certainly the dog knows it, right? So stress is mediated by hormones in the body, and specifically CRF, which is secreted in the brain, the hypothalamus. CRF stands for corticotropin releasing factor. And when an individual is under stress, they secrete CRF, and CRF then causes the adrenal gland to secrete cortisol. And both of these hormones are chronically elevated in people with diseases. People with diseases have more corticotropin releasing factor and cortisol circulating. And interestingly, having a disease causes more of these hormones to circulate too. So you get sort of stuck in these loops again, where the system gets revved up and dysregulated. I want to talk about childhood stress in particular. So this was a fabulous study, the ACEs study. Who's heard of the ACEs study, right? It's brilliant. So this is Filetti and Under, who were docs in the Kaiser Permanente system in California. And they became interested in the idea that early childhood experience, early childhood stress and trauma would lead to later development of chronic disease in adulthood. And so they reviewed some 19,000 patients in their system. And they said, okay, if you have one of these 10 areas of trauma, if you have these, what is the likelihood that you will later go on to develop a disease in adulthood? And the areas of trauma that they questioned were, was there psychological, physical, or sexual abuse? Was there emotional neglect, physical neglect, loss of a parent for any reason, mom treated poorly in the home, substance abuse in the home, mental illness, or criminal behavior? And they readily admitted, they said, look, we know that this is not a definitive list of all adverse childhood experience, right? I mean, you could easily add, you know, having a physical disability, having a learning disability, being bullied. I mean, the list could go on and on. But these were the 10 that they looked at. And what they found was that having adverse childhood experience was highly predictive of the development of diseases as an adult. And that could be diabetes, any form of cancer, heart disease, lung disease, and in fact, alcoholism as well. And what they found was that by the time somebody had 4 or more ACEs, there was a 7-fold increase in the likelihood of having alcoholism as an adult. So a fairly dramatic relationship. We can't conclude that there is causality, but a fairly clear relationship between the occurrence of adverse childhood experience and later development of addiction. So the question is this, right? We have this genetic predisposition. This is what you pop out of the womb with. This is sort of, do you have any talent for it, right? I mean, if you're a sprinter, you can practice and train and you can become very, very fast. But unless you have a real gift, unless you have genetics, you're probably never going to get to the Olympics, right? Well, the same's true for alcoholism. I knew a lot of fellas who tried very, very hard to become alcoholic. But at the end of the day, when it was time for them to stop drinking, they just did. And me and about 10% of my mates just didn't, right? So this is what you pop out of the womb with, genetics. And then this is what you experience. This is the early life stress, and then ongoing chronic stress, right? And we all have that. It's, you know, illness and mortgages and bosses and all the rest of it. And then somehow these conspire to alter vulnerability to disease. And so the question becomes, how do we get from genetics and priming life events, ongoing chronic stress, to vulnerability? And the answer is the business of epigenetics. So epigenetics is quite literally the science of how environment changes gene expression and hence vulnerability to disease. And it goes something like this. So all of our DNA exists in pretty much every cell in our body, and there are literally feet of the stuff. I mean, it's sort of a mind-bending thing to think about. All of this DNA, it exists and it's coiled and wrapped in a very specific way. And the way in which the DNA is wrapped alters the way in which it's read. So the DNA is read and given genes are translated and proteins are made from them, largely based on how the DNA is wrapped. And it turns out that corticotropin-releasing factor, cortisol, and indeed drugs themselves alter the way our DNA is wrapped. And so it alters the way we read it and make proteins from it. Example. This was a study that was done on rats. It wouldn't be very cool to do this study in humans. But what they found was this. They exposed rat moms to THC. And it turned out that the rat pups of the moms exposed to THC acquired this heroin-seeking task much more quickly than pups from moms who were not exposed to THC. And it turns out that the changes in the brains of the rat pups were all epigenetically mediated changes. There were profound changes in the reward system of these rat pups, and we're going to talk about reward systems in a minute. What they didn't expect was that the F2 generation, so not the first generation pups, but the next generation of pups, acquired the heroin-seeking task much more quickly too, and had the same epigenetics. So there's this kind of genetic scar, if you will, that's multi-generational, that's passed down, that's mediated through epigenetics. So experience altering genetic expression. So this little fellow is vulnerable. This is me. This is my 5th birthday, south of France, right? Rocking the pink flowery shirt and the wide lapel. Yeah, very stylish. Some of you may remember. Right? It's come full cycle. So I was a difficult kid, right? That was my job in our family, was to be the difficult kid. And I was that guy that didn't sleep very well and didn't eat very well and difficult to console, a bit fussy, didn't like his peas and carrots touching, you know, all that sort of stuff. And, you know, labels are too scratchy and socks bunch up under your feet. And my experience of life from fairly early on was kind of a solitary one. I mean, my view's obviously tainted by retrospect, but I remember just not really fitting in particularly well, not really fitting in my family particularly well, not really fitting in school. I mean, I had mates, but I was often kind of that kid playing by themselves a little bit. Yeah? And I remember not kind of knowing what all the fuss was about. Like birthday parties, I hated birthday parties. Other kids loved, they made me anxious, right? Christmas, I mean, I never quite got it. The idea that some guy's going to come down your chimney in the middle of the night worried me, right? So look, within about a year of this picture being taken, I got whooping cough. And I don't know if any of you have had whooping cough, but I have these paroxysms of coughing fits. And my mother did what I suppose any good English mother at that time would do. She went and got the bottle of codeine from underneath the bathroom sink. And I have a very vivid recollection of where the bottle of codeine came from and what the medicine tasted like, and that it made my tummy feel warm and it made my nose itch. But what I really remember is that when I drank that cough medicine, I felt content. I actually just kind of felt okay. I felt much more relaxed and at ease, and I actually wanted to kind of crawl up in my mother's lap, right, and put my head in her lap. So a very different experience, and what I would say is there's nothing bad about 5 or 6-year-old kids. This is vulnerability. That's a different experience than most children will have when given cough medicine, right? And I will say, too, that when I was exposed to opiate as a young man, that I had that same experience. That when I put opiate in my body, it made me feel content. It felt like a mother's touch, right? This is a very seductive sort of thing for someone to experience. So I want to spend a minute and talk about brain reward, and you really can't talk about brain reward without mentioning Laura Volkow, who is the head of NIDA at the moment and really defined most of these pathways with some help from some other people we'll talk about. So this is the reward circuit in the brain, and goes from the middle of the brain, the VTA, I should say that the reward circuit is designed to reinforce behaviors that promote our survival. And I'm sure you've all heard this, but it's just going to sort of review it for a minute. So, you know, food, sex, drinking, sleep, escape, fighting, all of those things. This is what that reward circuit does. And so it starts here in the middle of the brain, and when we engage in one of those behaviors, it stimulates cells in this nucleus accumbens, which is kind of the habit-forming part of the brain, the habit-forming part of the brain. People who have injuries to this area don't form new habits very well. And then projections from the nucleus accumbens go to the frontal cortex. And the frontal cortex is the executive part of the brain. It's the part of the brain that says, that was nice, let's do it again. Or says, that was nice, but let's don't do it again right now. And that's important because what isn't shown on this slide is that there would be sort of a big red inhibitory pathway going from here back down, kind of a brake pedal, if you will. So that when this pathway is stimulated, for example, by drug, we might say, yeah, that was really good, but this is not a good idea. Now, that pathway, the inhibitory pathway that comes from the frontal cortex down, is still forming until probably 25 or 26 years of age. And so when I say vulnerability, that addiction is a bully and it preys on vulnerable people includes people 16 to 26, peak exposure to drug, who do not yet have this pathway formed. Every person we saw in that film last night, the Cape Cod heroine, they're all 16 to 26. They're vulnerable. Their brains are not yet developed well enough to, again, given other predispositions, to say, no, that doesn't make any sense for me. This pathway the currency of this pathway is dopamine. Don't want to get into a lot of this, but dopamine is synthesized and it's released, and all of the elements of the synthesis and release and binding of dopamine, and indeed the uptake, are mediated by genetic polymorphisms. And if we have variants of those that cause us to release less dopamine or have it taken up more readily or not bind as many receptors, we have a low dopamine state. And these are states that lead us to have a predisposition to addiction, because addiction, as we will see, drugs of addiction will increase the dopamine in this system. I want to point out, too, that dopamine is not just about pleasure. You know, every sort of lay text says, dopamine is the pleasure molecule. There's a degree of that. There's a degree of pleasure. But because dopamine engages the survival machinery of our brains, it's really much more about want or need. It really is much more about want or need, and that's going to get to be important. So, this would be, these diagrams would be related to a probe in this area of the brain, so that when there is feeding, the amount of dopamine released in the nucleus accumbens increases directly afterwards. And the magnitude of the release of dopamine determines how reinforcing a given substance or behavior is. So food, if it's particularly good food, you'll get a slightly larger dopamine bump, and I suppose if it's particularly good sex, you get a larger dopamine bump over there. Right? So, all drugs of abuse cause release of dopamine in the reward pathway, but it is out of proportion to natural reinforcers like food or sex. Now that's important. So whereas we get a 100% or 200% increase in dopamine in response to these stimuli, with a dose of intravenous amphetamine, we get an 1100% increased dopamine release in the nucleus accumbens. So a dramatic increase. So these are very, very rewarding substances compared to natural reinforcers. I've included nicotine on this, just below amphetamine. As you can see, It is a dopamine release curve that really mimics amphetamine. It is not of the same magnitude, but it is a fairly good dopamine bump. And I believe that one of the things we'll look back on in treatment of addictions, hopefully in the not too distant future, is our lack of emphasis on nicotine cessation. One of the things we've really got to focus on is helping people stop smoking. We know that if people will stop smoking as part of their recovery plan, their likelihood of staying clean from every other substance is increased. And so, and this is why, because nicotine continues to kind of goose this system. It's sort of like having the pilot light lit on a furnace. So these are the substances and behaviors that cause dopamine release. These are all of the usual suspects: alcohol, opiates, cocaine, anabolic steroids, food, sugar, sex, love, people, right? Romance showing up in early recovery, gambling, exercise, achievement, right? How many recovering folks go on to become kind of hyperachievers? Collection, rage, violence, and then our newest addiction, right? Media. We now look at our cell phones between 200 and 300 times a day because we get a little blip of dopamine, you know. Social media, every time we get the old thumbs up, oh, I like you. It's like, oh. And we become very proficient at trying to boost this curve, right? So we're very clever. We boost this curve. This is sort of the additive effect. So the idea that I only smoke when I'm having a glass of wine. So the rationale behind that, although unconscious, is that you can kind of nudge this curve a little higher by having a ciggy with your glass of Chardonnay, right? And so the other thing that we do is that we layer these. We become very proficient at kind of figuring out just the right way to kind of layer these to optimize the dopamine curve. And so you'll sort of see people who, you know, say, well, I'm going to, you know, we'll do a little blow, and then we'll bang some steroids, and then we'll go off to the gym and we'll exercise a bit, and then we'll go back and smoke some weed and have a couple of drinks and go and have a lovely dinner with lots of sugar, and then we'll have a cuddle, and then I don't know, we'll go and gamble, and then we'll buy a bunch of stuff we can't afford. And then we'll get pissed off and beat each other up. And then we'll put it all on Facebook. Right. So the brain's seeing all of these huge, you know, these dopamine spikes, and the brain is always looking to find homeostasis and equilibrium. And as such, it's sort of like the thermostat, you know, on a heating air conditioning system. It says, look, these dopamine spikes, they're too big, they're non-physiologic. We've got to kind of damp this down. And the way it does that is by actually pruning back dopamine D2 receptors. So I mentioned earlier on that many people with addiction probably don't have enough D2 receptors. Part of the appeal then of drug is that we can increase the dopamine in the system, but as we do that, the system says, no, we've got to damp this down further and pull back D2 receptors. And of course what we do then is we increase the dose of drug more, right? And so you can already see this system's dysregulating. The system's dysregulating. As we pull back dopamine receptors, what happens is we become pleasure deaf to rewarding behaviors, spending time with friends, family, you know, whatever it is that we love to do, music, whatever it is, we become deaf to those things that really used to be fun. Anhedonia, can't experience joy. And what's interesting, you probably can't see it, we're actually looking at scans over here of brains, and it doesn't show up well, and I apologize for that. But the idea is this, that in all of the normal brains, there's coloration in the mid part of the brain, that's in the middle of the yellow bit, that shows D2 receptors. And in the addicted brains, they're not there. And what's interesting too is that it's not substance specific. I mean, whether it's cocaine, alcohol, heroin, amphetamine, and quite frankly, if you put you know, pornography or, you know, compulsive eating or any of those down below there, they'd look just the same. The dopamine receptors have been pruned back. They'd look just the same. And so this is part of the rationale of abstinence-based treatment, is to say, look, you know, the brain reacts the same way to all of these things, and behaviors, right? We've got to watch out for those. The leopard can change his spots.